All right, well, welcome everyone. We are glad that you chose to spend some time with us today in learning on how to begin a chronic care management program within your offices. We're going to concentrate today on the chronic care management service. We'll provide another video on the principal care management services. Chronic care management requires 2 or more chronic conditions. Principal care management requires a single high-risk condition for the patient. With me for this video today is our Contractor Medical Director, Dr. Joelle Vlahakis. Dr. Vlahakis has been in conversations with local providers, those within our jurisdictions, and national organizations to really understand how a practice can begin to offer CCM services and the value to their patients and to the practice itself in providing CCM services. Now, the information contained within this video today is obviously not the only way that you can begin a program. You, of course, can have your own ideas on this. WPS suggested and CMS accepted a proposal to increase the use of CCM services within our jurisdictions. And of course, this is Jurisdiction 5, which has the states of Iowa, Kansas, Missouri, and Nebraska, and then Jurisdiction 8, which is Michigan and Indiana. We want to do our part to provide you with the best information that we can so that you can provide these services to your patient. So, Dr. Vlahakis, before we kind of begin discussing how to start offering these services, can you provide us with some information on the purpose of the challenge that we've responded to and the value to both the patient community and the provider community for these services?
So the challenge is actually termed the Innovation Challenge Grant, and it really is designed to promote innovation within the confines of these programs. How can we do them better? So chronic care management, we know, is a holistic approach to caring for patients with chronic medical conditions, 2 or more. We also know that these conditions can contribute a great deal to morbidity, mortality, and things like hospitalizations and emergency room visits, neither of which are desired by the patients, the physicians, or the system. We also have observed that when patients receive chronic care management, good things happen for the patients and actually for the providers as well. For the patients, it means less fragmentation of care, fewer of those very disruptive emergency department visits and hospital stays, and general improved quality of their perception of the care that they get as well as the actual care that they get. I think another part of this challenge, which is really distinct, is our interest especially in managing to get this kind of care to people who aren't getting it, folks who live in an area where healthcare might be more fragmented. These are often termed areas of high deprivation indices, and it means that overall economic hardships are more, and there are harder access to things like transportation, good housing, and the like. So we're also very interested in making sure that these programs get to where they're most needed, and we've also observed that these tend to be areas where the programs are used less often.
So that talks to us about how valuable this program is to the patients in receiving the care, in their perception of what it is they're receiving. How does this benefit the provider community? What does this program, and starting this program, how does this help the physicians and practitioners who are actually going to bill for these services?
So that's a question I had. I'm an internist and a pediatrician by training. I worked in private practice, rural practice, and hospital practice most recently. And I was really concerned post-pandemic? Are we asking providers to do more? How can we do that when we know the level of requirements now? That interaction with patients is so important, and how can we make sure that that doesn't get disrupted? So what I found when I was talking with other providers is something rather surprising. Although it can be challenging to initiate chronic care management services for your patients within your confines of your practice and your workflow, once you get it going, it seems to really have some surprising benefits to providers. One is that with less fragmentation of your patient's care, it's a little easier to follow what's happening with them. The other thing that seems to happen is this wonderful benefit within your offices themselves. The folks who are providing those phone calls and those interactions, it really benefits everyone. People enjoy it, and it helps providers feel more connected to what's happening. Another thing that we discovered, which was a surprise, is that providers observed that they often, because they were managing fewer crises behind the scenes with their most ill patients, they had a little more time for face-to-face encounters, both with those patients as well as their other patients. So things ran a little bit more smoothly for them. And those were really some surprising outcomes that I didn't expect to find, but was very gratified to see could happen for providers.
And those sound fantastic. And of course, the CCM services, Medicare will actually reimburse for those. So you can also look at that as a possible revenue stream then for the provider office itself.
Absolutely. These physicians and clinics are doing the work already. So being reimbursed and honored for the work that they're doing really assigns value to something that they know instinctively they're providing.
Thank you. So what do you believe would kind of be the first step if an office is considering starting a CCM program? What would you look at first in order to start this?
So I think one of the most consistent pieces of advice we heard from providers who are already doing this is to start small. And that is to say, identify a small number of patients that you think might benefit from the service. A lot of them did this by looking at their roster, perhaps identifying patients with two or more conditions and seeing who stood out. Some of them already knew within their practices who might benefit. You can ask your front office people who's calling in most often, your nursing team. They can often also identify the small group of patients for you. Another thing we heard was to not only start with a small group of patients, but consider in larger practices starting this with one provider and maybe even one clinical team member who are kind of in charge of starting this, being able to observe what helps with their workflow before really putting this to a larger practice setting. Those kinds of things really helped. And then also making sure that you have not only support from the provider who wants to do this, and also your administrative staff, your leadership within your office, but also that you have patients who want to do this. And there's some specific things you might want to consider when you select those patients.
Okay, you mentioned the term heavy hitters. Can you expand upon that a little bit? What do you mean by heavy hitters when you're talking about your patients?
So sometimes I've heard them also called frequent flyers. It's a term that a lot of physicians use shorthand to talk about those patients who require a lot of care, whether that be in the office, they require a little extra time, or perhaps they've had an emergency department visit or even a hospitalization or maybe several hospitalizations within the past few months. Those are patients that you might actually think of first when you think of who might benefit from this chronic care management model.
Okay, you also mentioned once you identify your practitioner and the clinical staff that are going to be involved in this, you mentioned talking to the patient. So have a conversation with the patient on this, given the fact that unfortunately the patient does have cost sharing. CMS is restricted, they can't waive the patient's coinsurance or deductible. How would you start that conversation?
And cost isn't a small thing, so we really do need to address it. I think the first thing is to be transparent about that cost sharing and honest with them about what that means, that they're going to see, I'll say, charge for something that they might have expected just came with the service when they make a phone call to the office, for example. I think that's really helpful, especially if you're able to demonstrate for them what that might save them over time. So I know it was pointed out to me that the cost sharing or coinsurance for a hospitalization can be $1,600 for a patient. Well, that would pay for 5 years worth of chronic care management. So I think if you can be really honest with the patient about, yes, you're going to see this potential charge, but here's what we might get out of it, I think that's really helpful. I think the other thing is our own attitudes about the service. Are we positive? Are we excited about it? Are we passionate about making people have a better quality of life? Do we identify with patients about how disruptive a hospital stay is and how much we want them to be able to stay at home rather than going elsewhere? I think all of those things can really help patients understand where they fall into this. And the other thing that can be helpful too is being able to demonstrate, is if you know another patient who really likes the service, being able to share that story. Hey, what we've gotten is really positive feedback. I know overall when I talk with providers, they almost always recommend that I could talk to one of their patients because the patients inevitably find the service to be really helpful.
And I think patients would appreciate the additional interaction that they're having with that clinical staff. Because there's contact, the clinical staff is paying attention to kind of what's going on with the patient. I would think, if I was on the other end of that, that I would feel more taken care of, I guess you could say, because I'm having that additional interaction.
I agree, Ellen. A lot of this hinges on these unsolicited phone calls to check in with patients. And boy, does that make someone feel really important and cared for. I think also it's a holistic approach to the patient. It really encompasses their care provider, the people that are important to them, and their community. And it's more a glass half full kind of approach. Instead of what don't we have, we can't do something because we don't have enough. Really, this program looks at, okay, what do we have? How can we make the most of what we have in terms of resources that are surrounding the patient?
Okay, fantastic. Now, one of the things that the CMS instructions talk about is an initiating visit. And that's kind of the terminology that they use. Does every patient have to have an initiating visit? Do I have to call and make a separate schedule with them? What do I have to do with that particular terminology?
So I love the idea of initiating visits. I think they're wonderful. However, you only need to have one of those if you've not seen the patient in the last 12 months. I think that would be rather unusual if you have a cohort of patients that you know would work well with the program. They're likely ones that you have seen in the last 12 months and probably know fairly well. But let's say, for example, you have a new patient and you think that they might uh, fit well in this program. An initiating visit is your opportunity to sit down with the patient, describe the program, get them to consent to having the program, and then also begin to build your care plan, which, as you know, Ellen, is a really important foundation of having a very good chronic care management plan.
Okay, so if we have seen the patient within the previous 3 years or previous year, as you talked about, to start small, to start with your heavy hitters or frequent flyers. So if we've seen them within the past year, does the physician have to actually develop the plan, or can the clinical staff develop the plan? And kind of how would that look, do you think?
So that's a wonderful thing too. The clinical staff can develop the plan, usually under the supervision of the physician. I think it would be rare that a clinical team wouldn't check in with the physician at some point while doing this. You can consent over the phone. You can describe the program telephonically or over a virtual visit, however is comfortable for your program. And the clinical team surrounding that physician can develop that initial care plan.
Okay, fantastic. Um, so we've talked about the patient cost sharing and ways to kind of explain that to the patient, which I think are fantastic. So we've had the discussion with the patient. They understand the value of the program. We've received their consent. So they've said, yes, I want to have this. What do we do next? If we're a provider office, what do we do next?
So the next step is to develop the patient's care plan. And this is really a multifaceted uh, plan that encompasses, as we mentioned, a holistic approach to the patient. So believe it is very often things that providers already know. Who's important to the patient? Who's their caregiver? Is the caregiver able to manage things at home? What's their transportation like? What are their community resources around them? What else might be affecting the health of that patient? For example, do they have access to good nutrition, or do they live in a food desert? What are their extra stressors that they may have on them? For example, do they have home insecurity and the like? It is really meant to be along every axis, so that familial, the community, the emotional aspects of patients. Do they have losses that they're grappling with, et cetera. And I know, Ellen, you have some really wonderful visuals on what we need to do to think about the patient's care plan. If you want to fill in here, I know that you have a great deal of knowledge about all the things that could be part of that care plan.
Well, and we do have a lot of resources for you. We have several YouTube videos that go over the different aspects of chronic care management. And that information and the link to the playlist on our YouTube video will be in the description of the video itself. So, Dr. Vlahakis, we mentioned that the patient had to have at least two chronic conditions, and CMS defines those as expected to last at least 12 months or until the death of the patient, and it places the patient at high risk. And CMS goes into some of that language as to what is considered, what would be considered high risk. So when we're developing the care plan, do we only concentrate on those two or more conditions, or do we need to include the other things that are going on with the patient?
So absolutely, that care plan needs to include anything that's important to the patient and anything that's impacting their health. So even if you're managing someone with what you would consider rather severe COPD or emphysema, then that patient comes in with a shoulder bursitis, that's definitely impacting their quality of life, isn't it? So you want to make sure you include everything that's relevant to that patient's health, their lipid status, for example, tension, anything that might impact them past, present, or future. You also want to make sure that the care plan's updated with all of these encounters. That's a real key component of this. And then, of course, I think kind of my favorite part of the care plan is sharing it with that patient and making sure that they're a part of it, because they are an essential component, and that also allows them to feel like a partner in their own care rather than someone who's simply receiving passively these instructions.
And in conversations that we've had with the physician community, it is that care plan that really encourages the patient to make the changes they need to make in order to affect their own health. Would you agree with that?
Absolutely. I think that when you have that paired with those interactions with your clinical team who are asking them how things are going, it helps patients feel more accountable to things like their blood sugars, for example. They don't want to let you or your clinical team down. So they tend to start to move towards some of those um, goals that you might have had for them all along that perhaps seemed initially unattainable. They start moving towards things like using their inhalers more often as prescribed, and adhering to some of that care plan that you painstakingly outlined for them.
Okay, you mentioned a second ago, I think the example you gave was a patient with COPD who was in crisis. That brings up kind of an interesting question. The CMS requirements are that it is two chronic conditions as we defined before. Does the patient have to be in crisis in order to start CCM for that patient?
No, they do not have to be in crisis. In fact, it's probably a good idea to talk to someone when they are feeling pretty good. But this approach is very much a proactive approach rather than a reactive approach. You know, when I was growing up in medicine, so much of our thought process had to do with problems. What did people have? What did they come to us with? And we would respond with a treatment plan. This is really very different. This kind of approach reminds me very much of my work in hospice and palliative medicine, which is to say that you're really looking ahead to what the patient might need and trying to get ahead of it, if you will. Patients really appreciate that, especially if you explain why you want to manage this well. It is absolutely wonderful to have patients who are starting out well managed on a chronic care management care plan, because you don't want them to go into crisis.
Okay. So we've identified, how to start with the doctor. We've identified the patients who can be part of this program. We've developed our care plan. What do we do next? Is that the only service that's part of CCM, or for the monthly service, what do we do?
So ideally, what you want to do is to continually update that care plan after those check-ins. You want to be able to record your time that you're spending doing this, have a way to document those interactions, and you also want to make sure that the patients have 24/7 access to your staff members. And this is really an essential part of not only continuing a care plan, but maintaining it, really allowing those patients to feel like they're kind of ahead on the line, almost a fast pass, if you will, to your clinical team. It's wonderful if you're able to somehow uh, label those patients, put a banner on their health records such that anyone engaged with that patient understands that they're special somehow, that they really need to be able to reach that clinical team fairly quickly within uh, the workflow of your office.
Okay, that sounds fantastic. So we've had the contact. We're looking at the care plan. We're recording, documenting the conversation with the patient. We're recording our time. What's our next step?
So very important. We have value assigned to that time, value assigned to developing that care plan. The next step, of course, is submitting your bill for this, for reimbursement. One of the best practices we know is to wait until the end of the month, collect that time, and then submit your billing. This seems to be uniformly a best practice among the providers that we talk to.
Okay, because if I understand correctly, and this is reflected in some of the YouTubes we have like a primary code and then we have an additional time code. And if we wait until the end of the month, then we can gather all of that together. Is that correct?
Absolutely. And you want to be able to capture your time as best you can.
Okay, so what do we do then if our practitioner spends a little bit of time with that patient, they have a conversation with them, or they're updating the care plan, reviewing the care plan, monitoring that, and also our clinical staff i- is providing the care management, they're talking with the patient, they're assessing the goals and where the patient is on the goals. So we've got both parties who are providing service. How do we submit for that? How do we bill Medicare for that?
So Medicare allows us to choose one of those two to select from. Now, a physician time can count towards the clinical time, clinical staff time, but not vice versa. So the clinical staff time cannot be rolled into the provider time. Generally speaking, for most practices, it works very well if the physician remains in that supervisory role. That's not to say that they're not impacting the care plan or thinking about it or really helping to design it even, but more so that that clinical time is going to be probably most often done by the staff. And so when one submits the bill, you have to choose between the two, and usually it's going to be your clinical staff that's going to win out simply because they're spending the majority of the time doing it.
Okay. And so they submit the claim to Medicare. Medicare sees that they're the only provider who has billed for it, and therefore we make payment back to the provider office, and then they continue to do the services going forward. So, in kind of closing, is there any other insights that you want to share with our provider community on chronic care management services?
I think that it's just absolutely delightful to interact with people who have done this. It is hard at first, changing your workflow, developing a special system to capture the time, being able to have something set aside so you can write your care plan in the first place and then add to it as you go along. These things take a little bit of time and they do take some thought. But by and large, the rewards seem to outweigh those initial, someone called it the hump you have to go over in order to make this work. The workflows are a bit different. However, the patients really seem to benefit not only in terms of, you're looking, costs are down, and that's great. They're not being hospitalized, that's wonderful, but they also have this wonderful connection with the team of at your office or your clinic. That feels really good. That's a lot of the reasons why a lot of us went into medicine. And I think what's beautiful about this program is that we often say within medicine that the reason we go into it is because of those relationships with the patients. We really want them to do better. Well, this kind of program actually allows that to happen in a much more proactive, holistic way. And that is wonderful, especially as physicians. We want to be part of those larger communities. And when we access those resources and partner with those resources, things like transportation, things like Meals on Wheels, it feels much more like we're part of the fabric of that community. And I think that's a benefit none of us could have predicted.
Mhm. All right, well, thank you very much, Dr. Vlahakis, for sharing this information with us. I'm going to put a slide up on the screen real quick. All right, so what you have up on your slide, up on your screen right now, is just a survey that assesses your feedback on this particular YouTube video that we have put together. Now, the information that we have provided here today, both myself and Dr. Vlahakis, is not all of the requirements for the chronic care management program, but it's really good information on how you can begin a program within your office. You can take advantage of the other resources that we have available for you. CMS has a Medicare Learning Network Matters booklet on chronic care management services, and the URL or the link to that is in the description of this video itself. As we mentioned, we have additional videos on our YouTube channel. You want to choose the CCM or chronic care management playlist. If you found this information helpful, like and share the video. In addition to that, comment. We want your comments. Dr. Vlahakis and I both will be responding to any comments that we receive in YouTube. There's a whole comment function there. Please take the survey. Again, we want your feedback. The QR code is up on your screen. We also have a link to that survey in the description of this video. So from Dr. Vlahakis and myself, we just want to say again, thank you for spending the time with us today, and have an absolute wonderful day. Bye, guys.